meeting to order. And good morning and welcome. Due to COVID-19 and the Governor's Proclamation 20-28, we're meeting today via Zoom only, which we're going to continue to do until further notice. I am not in my normal spot, so I'll be doing the best I can today. I'm on vacation down in Arizona, which explains the lack of a suit. My wife told me a polo was going to be fine for today, so that's what I'm doing. Let's go ahead and introduce the board members. We're going to do roll call. Terry House.
Good morning.
Oh, good morning. How you doing today?
Good. How are you?
Good. You got to dive on that mute button, right? That's
yeah.
Skill test in the morning. Allison Folsom.
Good morning. I think you look great in your polo shirt.
Well, that might be a new trend. I doubt it, but there's always hope. Pamela Cruz.
Good morning. I'm jealous of Arizona. I'm stuck at home on spring break.
I heard it's supposed to be nice in Washington today, so it's
70 degrees today.
Hey, that's beautiful Washington weather. Carrie Schaefer.
Good morning.
Good morning. Amy McGuire.
Good morning.
Donna Hanson-Murray.
Good morning, zooming from Leavenworth.
Well, there you go. Is Leavenworth just as lovely as the west side?
It is beautiful, but a little chillier.
All right. Dan?
Good morning.
Morning, Dan. And Pete Cutler. Not expected today, but are you on, Pete? Okay. And Katie Hatfield from the AGO.
Hello, everybody. Good morning.
Good morning. And again, I'm Lou McDermott. I'm the chair of the board and the deputy director for the Healthcare Authority. With both board members and presenters attending virtually, it'd be really helpful for the board to hold their questions until the presentation is done or when the presenter pauses and asks if there's questions. Board members will also watch in case you raise your Zoom hand to indicate you have a question. The public will have an opportunity to provide general comments at the end of the meeting during the public comment period. Dave's going to give us an overview of today's agenda.
All right. Good morning, Chair McDermott, members of the board. We're trying to catch up on minutes. We're actually talking about how we, and you'll notice that the minutes are getting a lot more streamlined and shorter than the original days of the SEB program when we tried to do almost a verbatim transcript. Now that we're a little bit more into the setting out and not the full building phase of the program, we're going to try to streamline the minutes a little bit more, and that might help us keep them more in real time. Of course, we're not quite in real time when we're working on the end of last board season for you, but we'll do a little bit of time travel, and then we're going to have a presentation and ask for action on the USERRA leave resolution that was presented at last board meeting. Stella will join us and just give an overview of the annual rulemaking process. The agency does rulemaking on behalf of the program, and there are things that are codified as a result of your actions, like hopefully today on the USERRA resolution, and then administrative work that's under the agency's authority. We just like to give the board an annual briefing as we embark on that official rulemaking process. Probably remembered right at our last meeting, I think it was there were a few days left of the legislative session, so you never know what's going to happen in those last few days. But of course, the session is over. The governor's bill signing timeline is up, so we know the full results of the policy bills and the supplemental budget changes. And so Kate and Tanya are here to go through those. And then we're going to have our part 2 in our 3-part mini-series on dental benefit design, and have some more specific details and utilization information about the general dental benefit concepts that we were presenting at the last board meeting. And then as we close out, I have a couple of announcements. I do want to highlight for the board, Lou's opening comments talked about, we'll be using Zoom for the foreseeable future. It is important to know that the legislature passed an Open Public Meetings Act bill, and so if at the point that the public health emergency ends, we will at that point definitely be required to have a physical space for the meeting. We do intend, once we get to that point, to have what I'll call a hybrid meeting where board members and the public can attend like we have been for the last 2 years, but we will also have bigger space than the conference room you see today and have seen for the last year and a half, that A, board members who want to attend in person will be able to attend in person. B, staff will be coming in to present, knowing that there will be some people who are in person. And then the public, of course, will have a physical space to come. We're not quite there yet, but I did just want to say as a preview of coming attractions, that could happen by the end of the sports season. It might also be that it ends up being more of an next sports season piece. But I just want to assure you that if you want to continue to attend via remotely like you have for the past 2 years, that is going to continue to be an option, even when we do have a physical space meeting requirement. So we're starting to do some of the preparations for that work because it will be here before we know it. But I did want to highlight that. And then my last opening remark is I like to highlight what our backdrop is for the meeting from HCA. Today, you can see it behind Chair McDermott. We are viewing Whatcom County for today. So we've had some mountainous views for the last couple of board meetings, and now we're moving up north into the Bellingham area just to get a little bit more of the natural beauty of our state. And with that, I'll turn it back to you, Lou.
All right, thanks, Dave. So today we're going to go ahead and start with the approval of some meeting minutes. They're behind tab number 3. So we're going to vote on the May 5th, 2021 meeting minutes. Are there any comments from the board?
I'd like to make a motion that we accept the board meeting minutes of May 5th, 2021.
Excellent. Is there a second?
This is Dan. I'll second.
All in favor, say aye.
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 Any opposed? All right, the May 5th, 2021 minutes are approved as written. The June 3rd, 2021 meeting minutes. Any comments from the board? Do I have a motion to approve the minutes as written?
This is Dan. So moved.
Is there a second?
I'll second.
All in favor, say aye.
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 Any opposed? All right, the June 3rd, 2021 retreat minutes are approved as written. Next agenda item is policy and rules development. Emily Duchesne, regulatory analyst, policy rules and compliance section for the ERB division, is back with a resolution introduced in March and scheduled for board action today. After Emily's presentation, I'm going to read the resolution. Then I'm going to ask for a motion to adopt. A second, we'll invite public comment, and I'll ask for discussion from the board until we're ready to vote. The materials are behind tab number 4. Emily, welcome.
Thank you. Good morning, Chair McDermott. Good morning, members of the board. For the record, my name is Emily Duchesne. I am the regulatory analyst in the policy, rules, and compliance section for the ERB division, and we have one policy resolution for you to take action on today. Next slide, please. And here's the resolution for action. Next slide, please. Next slide, please. This slide and the next 2 slides are included in the presentation, so you will have them available as you consider the policy we are asking you to take action on. Next one and next one. And then finally, thank you. Okay, so some board follow-up. At the March 3rd, 2022 SEB board meeting, the board asked a question involving a scenario of a full-time teacher who would have benefits, but they left in November before they could get their benefits. And I want to speak to that for a minute. So I believe the question was about a school employee who was not anticipated to work 630 hours and was called to active duty in November before they established benefits eligibility. Now remember, a full-time teacher who was already anticipated to reach 630 hours at the beginning of the school year and who was returning from active service would still get benefits when they returned from active service, even if they left in November, because they have already established their eligibility under subsection 4A of 182.31.040. If a school employee did not establish eligibility before leaving for active duty, but would have otherwise become eligible based on the pattern they were working, then upon returning to their position eligibility for benefits could potentially be gained under subsection 182.31.0405B, which states that a school employee who is not anticipated to work, excuse me, to work at least 630 hours in the school year may later be eligible for SEB benefits when they actually worked 630 hours in the school year. And in that case, the coverage would then begin the first day of the following month, according to WAC 182.30.0803. So it depends. Next slide, please. Resolution SEB 2022-01 has been revised since the March 3rd meeting. We had explained at the time we introduced it that we determined the correct language needed to be employer paid SEB benefits and not health plan coverage. So we made the change accordingly, as you see here. Next slide, please. The stakeholder feedback we received was positive and in support of the resolution. We did receive one question that was not directly related to the proposed resolution, asking about military benefits for dependents. We also received a technical question on use of the words health plan coverage, and we explained that the final proposed language would be revised to say employer paid SEB benefits. Are there any questions on the, oh, please go back. Thank you. Are there any questions on this resolution before you consider taking action? All right, I'll turn it over to Chair McDermott.
All right, folks, I'm going to go ahead and read the resolution and then we'll go through the process. Resolved that, vote on resolution SEB 2022-01, school employees returning to work from active duty. Resolved that when a school employee who is called to active duty in the Uniformed Services under USERRA loses eligibility for the employer contribution towards SEB benefits, they regain eligibility for the employer contribution towards SEB benefits the day they return from active duty. Employer paid SEB-based benefits will begin the first day of the month in which they return from active duty. Is there a motion to adopt?
So moved.
Is there a second?
This is Allison. I'll second it.
Are there any comments from the audience? Dave, are you seeing any?
No, I just want to confirm for the record, Allison seconded. Who moved? Pam, thank you.
You're welcome.
And maybe as we go through this, are there any more votes on this? No, I think that was it. In the future, we'll just have to say who we are when we're doing that. Connie's quick, but not that quick. Any comments from the board?
Lou, may I speak to it?
Of course.
I appreciate the addition and clarification. We brought it up last time, so I think this was a good move on our part to make sure all of our employees continue their benefits regardless of when they serve in active duty. So I appreciate that.
Yep, and that's why we go through this process. It can be a little arduous at times, but we go through it so that we make sure that we don't miss anything. And the good news is if we do miss something, if something comes up, we always have the opportunity to amend. So this is going to be a roll call vote, starting with Amy.
Yes.
Pamela.
Yes.
Donna.
Yes.
Terry.
Yes.
Allison.
Yes.
Carrie. Carrie.
Yes.
Oh, there you go.
Yes, I'm sorry, my
That's
mute
okay.
slipped.
That's okay. The double and triple mutes are a little crazy on the system. Dan.
Yes.
And Lou. Yes. So resolution SEB 2022-01 passes. Thank you, Emily. Appreciate it.
Thank you, Chair McDermott. Next
Next
slide,
is-
please. Oh, I'm sorry. Do
Oh,
you want
I'm
me to
sorry.
finish out or do you want to
Yeah,
finish out?
No, I'm sorry. I'm sorry. I thought it was go time. So
No,
I got a little
it's okay.
excited.
So just real quick, the next steps are to issue guidance to the SEB organizations on this resolution and to incorporate the resolution into the SEB program rules. Next slide. Are there any questions? All right, well, thank you to the board. Thank you, Chair McDermott. Everybody have a good morning.
Appreciate that. Thank you. Next agenda item is 2022 annual rulemaking. Stella Ng, Policy and Rules Coordinator, Policy, Rules, and Compliance section for the ERB division, is going to share timeline and focus for HCA's annual rulemaking. Her materials are behind tab number 5. Stella, welcome.
Thank you. Good morning, Chair McDermott, members of the board. For the record, my name is Stella Ng, Policy and Rules Coordinator for the ERB division. I'm going to go over high-level information on this year's rulemaking and highlight the most significant changes and rulemaking actions we are considering making. No action is needed from the board for this briefing. Next slide, please. Here is the rulemaking timeline. In May, we will file CR 102, which is the proposed rulemaking on our proposed amendments and new rules with the Code Revisor's Office. In June, we will conduct a public hearing on our proposed amendments and new rules. After the public hearing, we will file CR 103, which is the rulemaking order, and rules will be effective 1/1/2023. Next slide, please. The focus of this year's rulemaking is divided into 3 different areas. We're adding clarity to rules to better administer and manage SEB benefits as identified by staff and stakeholders. We're making changes to comply with federal requirements, and we will implement Policy Resolution SEB 2022-01 adopted by the board just now. Next slide, please. Under Administration and Benefits Management, we're making global changes to include the addition of limited purpose flexible spending arrangement. We're including information on the methods to use when a subscriber wishes to cancel supplemental dependent life insurance and accidental death and dismemberment insurance coverage. Next slide, please. Post the implementation of changes to the long-term disability insurance benefits and implementation of SEB 2020-05. We noticed a couple of things should have been added to the rule, and we are adding them this year. They include adding clarity that when a school employee is on a leave of absence and maintains eligibility for the employer contribution, their premiums will be waived for the employee-paid LTD insurance for the first 90 days. We're clarifying a school employee's employee-paid LTD insurance will be automatically reinstated effective the first day of the month following the date they regain eligibility for the employer contribution towards SEB benefits. This is to align with the prior resolution about when a school employee establishes eligibility for SEB benefits. Next slide, please. And we're amending SEB program appeals rules related to brief adjudicative proceedings and formal administrative hearings. This includes clarifying that both the appellant and the HCA may request review of an initial order. We're adding new sections related to petitions for judicial review within the current process. And we're creating a new section on how to request the review of an initial order issued by the Office of Administrative Hearings. Next slide, please. Under regulatory alignment, we made a few changes to align with federal regulations, and this includes clarifying school employees cannot enroll in a medical FSA and a limited purpose FSA in the same plan year. We're clarifying the special open enrollment applies when a school employee's dependent has a change in their own employment status that affects their dependent's eligibility or another dependent's eligibility, such as the dependent child for the employer contribution toward the dependent's employer-based group health plan. An example would be Emily and Aaron have a son named Bobby. Both Aaron and Bobby are enrolled in Emily's SEB insurance coverage as dependents. Now, Aaron goes to work for Boeing and he becomes eligible for Boeing employer group plan. He wants to enroll Bobby to his coverage. Our current SOE rule doesn't allow the child to be disenrolled, and we're clarifying in the rule to allow both the child and the spouse to be disenrolled so they can both be enrolled in the Boeing plan. Next slide, please.
Stella, just to clarify, when you said Boeing, that's just an illustrative example. It's any other
Yes.
employer-sponsored insurance.
Yes, that's correct, Dave. Thank you. And I'll be glad to answer any questions that the board member may have.
All right, seeing no questions, Stella, appreciate the update.
Thank you.
Next up, we have Cade Walker, Executive Special Assistant, Herb Division, is going to provide a final wrap-up for this year's legislative season. Cade's materials are behind tab number 5. Oh, I'm sorry, tab number 6. Cade, welcome.
Thank you, Chair McDermott, members of the board. Cade Walker here to provide a wrap-up on this last session from our legislative year. I want to just make sure before I get there, I make sure every time I extend a sincere appreciation to all the staff that spend an inordinate amount of time rushing to do the bill analyses and be a substantial contributor to the legislative process. It's no easy task. It started off with quite the bang this year with a huge number of bills coming out and fiscal notes, and staff maintained a great level of professionalism in getting the bills done timely, providing important feedback to our legislature, and even incorporating a health equity lens on the analysis that were being done, which was a new process for this year. So I wanted to make sure I congratulate and call out the great work that the bill analysts and our managers did in reviewing hundreds of pieces of legislation, providing analysis and feedback and fiscal information to help move that legislative season along rather smoothly. So with that, I will get into the wrap up from this session. So next slide, please. The number of bills that we did analyses on this year, 169 bills in total. We had a larger number of lead bills this year, I think just based on the type of bills that were out in the mix of the legislature putting forward this year. So we had a lot more that our division was leading in regards to the rest of the agency, which was nice. It was nice to have those opportunities to dive into the legislation a little bit more. But 169 total bill analyses were done by our group. I also wanted to make sure I called out that we did have a substantial number of fiscal notes. You can see here 38 and 32 for a total of 70 fiscal notes, which was a new high as far as I've been aware. Fiscal notes, just for your edification for the board members, when we have a fiscal note on a piece of legislation, not every piece of legislation has a fiscal note, but when we do get a fiscal note request, either from the legislature or from OFM, or even one that we request internally, it substantially speeds up the process. And where a 3-day analysis would have been for a standard bill, now we have a 1-day process to get that bill analyzed, get feedback from our partners, get that reviewed and over to the fiscal team so they can incorporate that information and use it to make a fiscal note determination of what the fiscal impact of legislation is. So our team did a really great job getting those done timely. And again, my appreciation to the team. Next slide, please. Here's our funnel of bills that we had that were of lead priority that we tracked through the how a bill becomes a law sort of process. We did have 7 bills that we tracked this year from a high lead perspective that did make it all the way to the governor's desk, and everything that I'm aware of so far has been signed by him. So next slide, please. For the next 4 slides, I'll go over the pieces of legislation that were passed, including the next 2 slides are the ERB-led analyses that had a high priority to them, meaning that they had a greater than $50,000 impact, or they might cause a change in our rules or have a significant impact on the program. So the first 2 slides are those bills that were high impact. 1052, this is a bill you probably remember from last year. This is the bill that allows for large group employers to integrate performance guarantees. I'm sorry, I was blanking on the word. Performance guarantees into our contracting with insurance plans. This is a standard industry practice and one that we have had in our portfolio for a long time. We were just making sure we got the insurance code amended in a way that made sure that we were in alignment with industry practice and what we were doing, so we can keep holding the feet to the fire of our carriers and making sure that they're providing excellent service to our members. 1688, out of network healthcare. This is an expansion on the legislation passed in 2019 regarding surprise or balance billing. It expanded the services that are included in the prohibition against surprise billing. It now includes services that are rehabilitative services after an emergency visit. So if you end up in the hospital for something that ends up resulting in needing some extensive physical rehab afterwards, where you're still as part of the episode of care, all of those services are also now included in the surprise or the prohibition against surprise billing. So a very good piece of legislation for consumer protection purposes. 1689, biomarker testing prior authorization. This one, just so I'm really clear on it, requires health plans to exempt enrollees from prior authorization requirements for biomarker testing for stage 3 or stage 4 cancers or recurrent, relapse, refractory, or metastatic cancer. So it's, again, helping to lower some of the barriers to care for the population. Senate Bill 5532, the Pharmacy Drug Affordability Board, that was passed, and I believe I'd had a fairly in-depth conversation with the PEB board about this, or we had a member that was a lot more interested in this drug affordability board. It did have a lot of iterations, and what it came down to when it was passed is a board that's going to be able to review certain types of drugs that meet certain qualifications, whether it's cost or the cost if it's a name brand, the cost if it's a generic, how long it's been on the market, and some different factors that they're able to then go assess that affordability and make recommendations to the legislature, or make cost recommendations about how much those drugs can be priced at. It's not as, I think it's a really great start. I think we'll continue to see it expand. And of course, HCA will be an integral part with that work as it moves forward. Next slide, please.
As you transition, I apologize if you said this and I missed it, but I want to make sure the record's clear that the 1688 has been signed by the governor. When we produced the slides, we hadn't quite been able to confirm that it had been acted on by the governor, but I didn't want people to think that the governor's signature deadline has passed, and it's just a creature of when the slides were produced. So that bill is signed. Thank you,
Dave. I didn't catch. I was only looking at the numbers and not the sign. So yes, all the bills, as far as I recall, I mean, I went through this morning, everything has been signed that I have listed here. And yeah, as David said, it would just, by the time we produced the slides last week, the bill hadn't been signed yet. So, but everything else has been signed so far. Thank you, Dave. Continuing on, Senate Bill 5546, insulin affordability. This is lowering setting the 30-day supply cost of insulin. There's legislation that was passed last year that lowered the price to $100 for 30-day supply. This for the next year, it will be $35 for a 30-day supply. That lasts for a year. And I think that's in conjunction with the insulin work group that's on an upcoming slide. But the legislation that was passed further reduced the monthly cost of insulin to no more, cap that cost at $35 for a 30-day supply. We're bringing that down from a $100 a month cap that is currently in place. 5610, pharmacy drug cost sharing. This is changing up a bit of the way of how coupons are applied and what the coupons apply to for member cost sharing. And then 5702, donor human milk coverage, allowing for or requiring coverage under certain circumstances for newborns to receive donor human milk to assist in their early development. I want to stop there and see if there's any questions about the last 7 bills that have been kind of a higher priority for the SERB program for PEB and SEB. Okay, I'll move on. Next slide, please. I'll try and go through these ones a little bit quicker. 1329, this was some of the legislation that Dave had mentioned earlier that changed or kind of codified some of the emergency rules that have been put in place for open public meetings. Our understanding so far is there's not really any significant impacts to the way that our board meetings or other public meetings are held currently. We're looking at things as there may be some other aspects of integrating it into our work that we need to consider from an administrative standpoint, but nothing that will change up the current process that we have available for our board meetings or other public meetings that we hold. 1651, postpartum contraceptive, ensuring that there is coverage available for contraceptive postpartum for women. Not one that was a real high priority. Again, all of these bills were not high priority for our division, While they certainly had some aspects of our agency that had a higher emphasis on the analysis they were conducting, for the ERB, meaning the SEB and the PEB programs, these pieces of legislation did not rise to a high level or high priority for us. The impacts of them were relatively small to our programs. 1675, dialysate and dialysis devices, just kind of expanding and clarifying a little bit of the coverage requirements for those services. 1728, the insulin work group reauthorization. This is reauthorizing the insulin work group that has been formed for, I think, a year, maybe two now, but it reauthorized and provided additional funding for that work to continue of assessing the needs for those who have diabetes and the insulin and other needs of those individuals. 1761, opioid reversal by emergency department nurses. This is just allowing for emergency department nurses to provide prescriptions for opioid reversal medication like naloxone for individuals who present to the emergency department with due to an overdose from opiates. 1851, abortion care, it is just further codifying the state's right for women's care with regards to abortion services. 1881, birth doulas. This is one that I actually find to be really interesting. It is providing a licensure path through the Department of Health to have licensed birth doulas, which are available to help and assist women during their pregnancies, during and at the time of delivery and postpartum care as well. Expanding the services and the types of services that are licensed and therefore able to be reimbursed through insurances for expecting mothers. Next slide, please. 1893, emergency medical technicians and public health. This is in response to COVID-19. It allows that, it provides that EMTs in the state are authorized under emergency circumstances to provide expanded services to assist in the delivery of vaccines and other sorts of services that we want to be able to tap into as many medical resources as possible during emergency situations like the COVID-19 pandemic. 5508, insurance guarantee fund. This is expanding some of the insurance types that are eligible to participate in the state's insurance guarantee fund and further authorizing that fund with additional funding. 5518, the occupational therapy licensure compact, which allows for, that requires the state to participate in the multi-state occupational therapy licensure compact, which will allow those who are occupational therapists in the state to be able to practice in states that are also in the compact, which I think also that does include Idaho and Oregon. So those occupational therapists that live on the borders of states are able to practice in those other states as well, without needing to go through additional licensure for those states. 5539, educational service district funding. This is funding that was provided for the ESD employees who are represented and currently participating in the SEB program. It requires that the state fund those positions for represented employees. In the ESD system, there's about 3,500 employees total, of which there's around 100 or so represented employees. And those ESD, there's only 2 ESDs that actually have represented employees who are in the SEB program. You may recall that when SEB launched, initially the plan had been that ESDs, all 9 of the educational service districts, would mandatorily participate in the SEB program. They were able to lobby the legislature to get an exemption till 2024, though the represented staff in their educational service districts did need to participate as not to throw off the bargaining, the collective bargaining that had been done. And so represented employees have been participating in the SEB program since the launch in 2020. This bill was just providing funding or ensuring that there's funding provided for those employees directly to the ESDs from the legislature, only impacting about 100 or so. We kept an eye on it, very small impact for us. I'm sure the 2 ESDs that are receiving funding for it are very appreciative of that. 5765 regarding midwifery. This is just expanding the scope of services and licensure requirements for midwives. And last but not least, 5793 regarding state boards and commissions and other volunteer positions, and having a stipend available for participating members who, due to economic circumstances, may not otherwise be able to participate. So it is something that is being made available to certain board members to ensure that we're able to pull in a diverse group of individuals to serve on our state boards and commissions and other organizations that we want to have a diverse and diverse voice of individuals that we hear from, and making some funds available to them to assist if they need to take time off from work. And with that, I'd happily take any questions about this session.
Any questions for Kate from the board? Kate, appreciate it. And again, appreciate all the staff's work that goes into session. It was a particularly robust session with the influx of federal money and some of the rebound on the state coffers as well. So they were very busy.
Yeah, we were. It's good to be done, and I appreciate all the support and glad to take a breather before we get ready for 2023.
All right, take care, sir. Thank you.
Thank you.
Next agenda item, 2022 supplemental budget update. Tanya Dool, our finance manager from the Financial Services Division, is going to provide a final update on the enacted final supplemental budget. Her materials are behind tab number 7. Tanya, welcome.
Good morning, Chair McDermott, members of the board. For the record, my name is Tanya Dool. I'm the ERB Finance Manager, and I'm here to give a brief update on the final supplemental budget. I was here last month, I believe it was March 3rd, and we at that point had both the House and the Senate proposed budgets. With only a week left in session, I'm here now to, at that point, there was only a week left, I should clarify, but now I'm back to give you an update on the final conference budget. So next slide, please. This second year funding rate, you'll see in bold there, of $1,026 was reduced from the original funding rate that was passed in the biennial budget of $1,032. That reduction was utilizing about $10 million in surplus, and the legislature chose to reduce that funding rate in the second year and utilize some available surplus. As a reminder, the funding rate is per employee per month. It's adequate to maintain current level of benefits, plus some additional decision packages I have on the next slide. And there are no concerns with any of the underlying assumptions within the modeling. Next slide, please. These should look fairly familiar. These were all included in both the House and the Senate proposed budgets, as well as the governor's proposed budget. So I will walk through these 4 decision packages fairly quickly, and feel free to jump in and interrupt if you have any questions. So first, we received 4.5 FTEs for the SEB program, a total of 9 FTEs between the PEB and the SEB programs. Those FTEs are for customer service staff, as well as an FTE within the portfolio management section. Next up, we received procurement resources. We received $1.4 million within the SEB program for some future procurements that are going to be upcoming, which I think we will be talking about in future board meetings. We also received $350,000 for a mental health parity analysis to be able to look at the mental health benefits within the Uniform Medical Plan. This also was a larger decision package of a total of $700,000 between the PEB and the SEB programs. And then lastly, we received $970,000 for 5 FTEs to do some support for and basic maintenance and operations of the SEB My Account system. Dave, anything on any of those 4 you want to add? I know we've talked about them quite a few times.
Just a couple of quick things. Tanya was right. With the procurement resources, we have a couple of presentations planned for May to share some insights about those upcoming procurements that we are already working on. And then I just want to draw attention to that last one, the SEB IT maintenance and operations staff, an extraordinarily important decision package from my vantage point. These FTEs, as we are already leaning forward and beginning the hiring process, and not waiting until July 1st, but trying to begin that hiring process to get them on board as soon as possible. Once they are more familiar with our systems and up and running, I really see this as an opportunity to break some of those log jams on some features and requests that we're hoping to incorporate in future versions of SEB My Account. We have a variety of requests for enhancements and ideas, which goes into the maintenance and operations bucket. And so with these staff, I'm hopeful that we will be able to begin tackling some of that list and being able to support the requests that we're hearing from members' ideas, school districts' ideas, and our own ideas for some enhancements to that system. We're really excited to have the full 5 FTEs that we really did need to be able to keep SEBB My Account advancing forward in its operational abilities for everyone.
Okay, thanks, Dave. Next slide, please. This last slide here is probably the newest item that I did brief you on last time. It was only included in one of the proposed budgets, but it did make it through to the final conference. So I will walk through this slide and then we can pause again for any additional questions. So HCA received a total of $500,000 between the PEB and the SEB program, split each. So the SEB program received $250,000 for us to conduct a study of the Uniform Medical Plan Administration. So by next June, we must submit a report to the legislature that includes the following bullets. So administrative services provided prior to 2010 and those that have been procured since, and what elements could be administered by HCA or through discrete provider contracts. Also, we need to compare the administrative costs before and after the use of the current TPA contract, any assumptions on claims impacts and performance guarantees, as well as an implementation plan for HCA to resume some or all of the administration at the end of the current contract. So I will pause there, and then I have 2 other small bullets. Any questions on this report or anything, Dave, you want to add?
I'll add a little bit just for some more context and just to refresh memories from last month's meeting. This is about our current TPA, third-party administrator contract with Regents for the Uniform Medical Plan. You may remember that the agency signed the current contract was signed and began on the same date as the SEB program launched, January 1st of 2020. The length of that current contract, so kind of the end of the slide here notes, implementation plan for the end of the contract, the current contract. The current contract goes through December 31st of 2029. And so we're sitting here in 2022, and that may seem like it's really far ahead of time. And just a general reminder, it's not that far off when we're talking the size and scope of these types of services and this type of contract. When we did the procurement that resulted in the 2020 contract, we began those works internally in the Healthcare Authority in 2014. So it is a rather, because of the size, scope, and complexity of the Uniform Medical Plan, it does have a very long on-ramp to change direction on something of this magnitude. So it's not a foregone conclusion that anything that there will be a resumption of services at the Healthcare Authority. There's also not an assumption that there won't be some resumption of some services at the Healthcare Authority. That's really the focus of the report. We anticipate that this report, would be considered during the 2024 or even 2025 legislative session. And if there was direction at that point for the Healthcare Authority to resume some services, that we would begin that path over that 5-year period as we march forward to 2030. If you can believe it, to transition some of those services back to HCA. It's important to remember, SEB didn't exist in 2010, but prior to 2011, the Healthcare Authority did many services, including direct provider contracting with facilities and providers in the state. We did not run claims administration directly. We did have an administrator for claims adjudication, but a very prominent thing that Healthcare Authority directly did was provider contracting. So we're just, one of the reasons that we know that this is something that there's of interest in having this report is with SEB coming on, the scope and breadth of the Uniform Medical Plan, essentially doubled. We got quite a high enrollment in the Uniform Medical Plan from SEB, and when we have almost 400,000 covered lives between both programs, it's a natural question for looking at is there, evaluating the efficiency of current and other approaches for handling the administration of the self-insured plan. So just a little bit more context there, and now see if there's any other questions before we move back to Tanya and her other points.
All right.
Any questions? So Tanya, your other point.
Thanks, Dave. So there were two other items that passed within the conference budget that were not necessarily within the PEB and SEB sections of the budget that I just wanted to note. The first is regarding fertility, which was in the OIC section of the budget. So in consultation with the OIC, HCA will complete an analysis of the cost to implement fertility benefits as described in the 2021 Department of Health mandated benefits sunrise review. And that report must be to the governor and appropriate committees by the end of the biennium, so June 30th. And then the second one was around palliative care. HCA, as the agency, received $250,000 to design a standardized payment methodology for palliative care for both the Medicaid and the PEB and SEB programs. So those were the last two items that I had to mention, and I will pause for any questions.
I just want to highlight, this is Dave for the record, that both the palliative care and the fertility provisions that Tanya just described are for the agency's support on all of the programs at the Healthcare Authority. So it's not just PEB and SEB, it's also the Medicaid program. So it's an analysis of all the purchasing power of the Healthcare Authority, the breadth of the purchasing power of HCA. And when Tanya said the end of the biennium, and she said June 30th, just to clarify, June 30th of 2023, it's not 60 days from now, it's a year and a couple of months out. And as we do some of that work, I can see maybe next board season bringing some information about the specific fertility benefit design that is being reviewed. That was the result of the Department of Health Sunrise benefit design review process. So we'll bring some more information of that as we get further into the details and begin providing support to OIC about that report.
All right, thanks, Dave. Thanks, Chair McDermott.
Any additional questions for Tanya? All right, thank you, Tanya, appreciate your time. Our next agenda item is fairly lengthy. We've got about 45 slides, and so I'm wondering if the board would like to take a 5-minute break, 10-minute break, get themselves in order before the next presentation. Any takers on that?
A couple of thumbs up, virtual
okay.
Thumbs up.
Why don't we go ahead and do that? It's 9:49. Let's reconvene at 10 o'clock.
It's 9:39, Lou. So do you mean?
Oh, that's funny.
Oh.
My
Oh, I'm
my
sorry. I'm wrong. That's the second time I've been wrong today, for the record.
Okay, it's totally possible it was me. I'm in Arizona. The clock may have done something weird. I believe it's 9:49. Why don't we go ahead and go till 10 o'clock and we will reconvene.
We're ready here at Olympia.
All righty. All right, folks.
Okay.
Our next agenda item. Dave, did you say something?
Nope, go ahead, sorry.
Okay, sorry about that. Next agenda item is the 2024 Uniform Dental Plan Dental Benefit Design Options. Ellen Wolfhagen, Senior Account Manager in the ERB Division, is back to share specific proposals for benefit design enhancements and to start the prioritization discussion for possible changes as early as 2024. And I know when we say as early as 2024, the ball does move slow. It does take a lot to make these changes. Ellen's materials are behind tab number 5. And like I said, it's a fairly lengthy lengthy presentation. So Ellen, I'm assuming that if folks want to raise their hand and chime in, they're free to do that.
Yes, that would be great. Just a sound
Awesome.
check. Can everybody hear me?
Yes, ma'am, we can hear you.
Okay. Good morning, Chair McDermott and the members of the board. As Chair McDermott said, I'm Ellen Wolfhagen, the Senior Account Manager in the Herb Division. I'm going to lower my mask because I'm having trouble. Next slide. The objectives for today's meeting are to present specific proposals on the benefit design enhancements for the Uniform Dental Plan, UDP. We'll have an initial prioritization discussion and explain how prioritization relates to the decision package process. Slide, please. Brief review. The current UDP plan has deductible of $50 per person, up to $150 per family. Class 1 preventative services are covered at 100%, Class 2 filling 80%, Class 3 crowns, bridges, and implants 50%, TMJ 70% with a $500 lifetime limit, and the annual plan payment is $1,750. Just to note, this is different than the medical plans in that this is what the plan actually pays out, not out-of-pocket limitation.
And Ellen, I just want to make sure on preventive services, it's 100% covered. Is there any nuance with network status of the providers on that coverage?
Yes, thank you, Dave. So the UDP has two networks. One is called the Preferred Provider Network, and the other is the Premier Network, which is listed as non-PPO. Premier providers are paid at a higher rate, and so the coverage is less. For Class 1, it is 80% coverage, Class 2, 70%, Class 3, 40%. And I will repeat this as it comes up later. Slide, please. These are the options that we discussed and introduced last month. These are presented now in order of the population impacts from greatest to smallest. So annual plan maximum would affect the most people, then composite posterior filling, then incentive plan, and then deductible for children, and then TMJ. Next slide, please. Slide, please. So the annual plan maximum, as I said, is $1,750. That's the amount the plan pays. And UDP, as we just noted, has a difference between what is paid when there's a premier provider or a preferred provider. It is important to note that the $1,750 applies for all providers, so regardless of who you see. But if you see only premier dentists, you would have fewer services available in that $1,750. Of the plan maximum, only about 4% of the SEB population exceeded the plan limit in 2021. 20% of those were children under the age of 18, which is about the same proportion as the SEB membership. Slide, please. While preventive services are covered at 100% with a PPO, they currently count towards the plan maximum. This can have an impact, as I will show very soon, if you have more expensive services early in the year and need preventive services later. Next slide, please. When we talk about preventive services, we're talking about cleaning, exams, x-rays, periodontal maintenance, and fluoride application. Next slide, please. So I'd like to walk through an example. Katie needs extensive dental work done. She has a series of appointments for x-rays and oral surgery in January. The annual allowed amount is $3,500. For simplicity's sake, we are concentrating on the allowed amount. I just want to note that there's a difference between the billed amount and the allowed amount. And the dentist has to write off difference between two because there is no balance billed billing under UDP. In April, Katie returns for periodontal maintenance, the deep cleaning, and she must pay the full $200 allowed amount out of pocket. Slide, please. Now we're going to walk through the example of Katie's claim. So in January, she had x-rays. The allowed amount was $100. It's paid as 100%. As noted, UDP pays the $100 and the member pays $0. So again, the proposed benefit change here is to remove preventive services from the annual plan maximum. We would continue the annual plan maximum at the $1,750 level. And again, that would cover PPO and premier dentist. But this would create an incentive for using preventive services, which can improve overall health by establishing good oral health routines. It's also important to note that this creates health equity by treating dental preventive services the same as medical preventive services, where the deductible doesn't apply, which is also true here, but on the medical side, they don't count against the maximum out of pocket. So creating this exception would equalize the treatment of preventive services. Slide, please. So let's look at Katie's claims again under the proposed change. So in January, x-rays exactly the same because they're covered in full. She's seeing a PPO dentist. It's paid at $100. But on the oral surgery, and again, the deductible works the same way. It comes off the top. The plan pays the full 50%, which is $1,675. That's half of $3,350. And there is a remaining balance of plan payments of $75. And the member pays $1,725, which includes, it's the half of the oral surgery benefits plus the $60 deductible. When she goes for periodontal maintenance in April, again, it's $200. It's paid at 100%. The plan would pay $200 because under the proposed change, they would pay in full for preventive services and not counted against the plan maximum. The member would pay $0, and there would still be, at the end of all of this, another $75 remaining. Slide. So the difference in the out-of-pocket costs under the current plan design, the member is paying $1,950. As they paid $17.50 towards the oral surgery and then had to pay $200 for the periodontal maintenance in April. And under the proposed benefit design, the out-of-pocket would be $17.25. The note is that this is April and she's having a periodontal maintenance exam, but they're typically recommended to have 3 to 4 in a year. So under the proposed change, she can pursue those visits without a concern about paying the additional amount for those visits.
Before we move on, I just want to highlight, I think many of us have either done this ourselves or have family members or friends who have done this, where you're near the end of the year, you find out you need a filling, or you might have a root canal or a crown coming, and a lot of people balance those interests going, I want to make sure that maybe some people will, depending on how much coverage they've used in a year, will try to get it all in before December 31st, or others will be in a position where they go, oh, I got to wait till January 1st so that I get more plan coverage in. And part of that is driven by the cost of preventive services being included in the annual plan maximum. I don't want anybody to be disillusioned that preventive services alone could get you to $17.50. As you know, I can reveal my own PHI. As somebody who's had periodontal maintenance for most of my life, you know, it's about $625 a year that's in preventive services. And, you know, I go every 90 days. It's like changing my air filters at home. Every time the seasons change, I know I need to go to the dentist. But as all of those things add up, and many times people who need periodontal maintenance have more fillings, you know, it kind of goes hand in glove with extra services. And so it just sort of starts to eliminate some of that burden as you're sitting looking at your budget, your kitchen table budget, and going, am I going to do this now? Am I going to wait until January? Do I want to make sure I get it in before the end of the year? It starts to just relieve some of those pressures about possibly even delaying care, and delaying care has its own implications on our health. So just a lot of different things that kind of relate to this concept, just to get people's minds thinking about it.
Thank you, Dave. Next slide, please. You will see this format in all of these options as we go through them. We'll end with sort of some insights into the change and who could benefit from it. So on this, again, specific proposal, we would exclude preventive services from the annual plan maximum. As you can see, there were 57,000 members in SEB who were not seen at all in 2021. 200,000 plus were seen, but almost everybody could benefit, because if you had preventive services, this change would, as Dave explained, allow more money to be used for other services. And perhaps if you didn't go, maybe the cost of preventive services was an obstacle, and this would relieve that. Let's move on to the next one. Next slide, please. Next slide.
Deanna, we see that we have a question about this one before we move on.
Yeah, Dave, this is a question I think I'm going to ask for each of the proposals, and that is this a benefit that is usually provided in Delta's book of business?
In my materials, in the appendix, there is a market analysis for each of these options that shows the Delta book of business. And by that, we mean the large employers such as Boeing, Alaska Airlines, Amazon, as well as a comparison with what the WEA plan had prior to SEB.
So I will say on this particular one, our benchmark in the appendix doesn't quite draw the distinction about whether preventive services are in or out. So Ellen, if you might be able to share some thoughts if you have them, or we can bring that back on this particular one at the next meeting. Ellen's nodding to me, she's sitting here in the room, that she wants to make sure on this particular one that she follows up on that when she comes back in May. Because our table in the appendix doesn't get into the nuance of preventive services in or out. So thanks, Dan, for that question. We'll make sure that's partly why we have a 3-part mini series on this one. We'll follow up with
Thank you.
Okay, moving on to composite posterior filling. So just a little bit of background. Composite is a material that usually is two-colored, and it is covered right now under UDP for anterior front teeth filling without any difference. For posterior teeth, which is molars and premolars back, the coverage is limited to what is covered for amalgam filling. Amalgam, as you may remember, is metal filling. So we're looking at whether we can, next slide please, move to covering composite filling to the same extent as network coverage. And Dan, this is one place where the network distinctions of Delta Book of Business are a big factor. So Joe requires the filling for a back molar, and we're just assuming simple fillings here, and we're going to assume that the deductible has already been paid. Joe's out-of-pocket costs, if the dentist provides both amalgam and composite options, are compared below. So for the billed amount is $200, the network allowed amount is $125, the SEB plan allowed amount is $125, plan payment is 80% of the $125 or $100, so the out-of-pocket would be $25. That's for the amalgam filling. On the composite filling, the billed amount is the same, $200. The network allowed amount, this is what Delta's book of business would allow, is $150, so a higher amount. But the SEB plan, you'll notice, is $125, and that's because currently UDP limits the reimbursement to the same as the amalgam amount. The plan pays 80% of $125 again, so the $100, but the out-of-pocket would be $50. Next slide, please. So if we were to make the change to include Class 2 coverage for posterior composite fillings at the network allowed amount, instead of the $50 that Joe had to pay, his out-of-pocket would be $30. Again, the Class 2 coverage would remain at 80% for posterior amalgam if that's chosen. Next slide, please. So you might be asking how many people had fillings in SEB. 68,609 members, so that's people who were seen. However, there's many more fillings, and the reason is, on average, people have about 1.8 fillings per year. The split very clearly is in favor of posterior composite filling, 5 times as many. And so those are the people that would most likely benefit from more coverage for composite filling. Slide, please.
Real quick, as we move on, Dan, because I know you're going to ask, you asked the question, so I'll try to highlight it. In general, the appendix will highlight that the pre-SEB WEA plan had coverage for posterior composite fillings at a different base rate, but there was general coverage. And that in the large employer market, generally large employers, self-insured plans haven't gone in the direction yet of widespread composite posterior composite fillings, but some smaller fully insured groups, employers, do include this feature. So I'll just try to highlight the appendix piece as Ellen moves to the next one.
Thank you. Okay, our next design enhancement is an incentive plan. So I just want to review for a second the current coverage limits. Class 1 at 100%, Class 2, 80%, Class 3, 50%, with a reminder that if you see a premier provider, it would be Class 1 at 80%, Class 2 at 70%, and Class 3 at 40%. Slide, please. So the concept here is if a member uses preventive services, it would increase the coverage for Class 2 benefits in the following year. So in year 1, you see the dentist. In year 2, you have more coverage. For example, if you were seeing a preferred provider and you had 80% coverage in year 1 and you saw your dentist for preventive services, in year 2, you would have 90% coverage. There were 199,000 members of SEB who had at least one Class 1 visit. And a reminder that most preventive services occur more than once. The actual number of procedures is much higher. If you had no preventive visits in, let's say, year 1, it would decrease the coverage for Class 2 benefits in the following year. Again, 57,860 members out of the total SEB population of 257,86 were not seen at all in 2021. So they would, if the plan were an incentive plan, they would face a decrease in coverage. A reminder, these are the kinds of things that are preventive service visits. Next slide, please. This is a diagram that shows how the incentive would work for year 1, year 2, and year 3. So year 1, everybody would start at the current level, which is Class 2 at 80%. Please note at the bottom, Class 1 is always covered at 100%, Class 3 is always covered at 50%. Again, those are for preferred providers. In year 2, you have to ask the question, was there a preventive visit in year 1? If there was, Class 2 is covered at 90%. If not, Class 2 is covered at 70%. Let's move to year 3. Was there a preventive visit in year 2? If yes, you would stay at 90%. If no, you would go down to 80%.
That's if you had had a preventive service in year 1. You're on the upper horizontal row at that point. Now you're going to go through the lower row where an individual didn't have it in year 1 to affect year 2. We have to ask the same questions in year 2. That's the fun diagram.
Thank you, Dave. So the bottom box, the bottom right-hand box, would show what happens in year 2. So they started, because they didn't have a preventive visit in year 1, in year 2, they were at 70% for Class 2 coverage. But the question is, did you have a preventive visit in year 2? If yes, you're going to move up in year 3 to Class 2. But Class is at 80% coverage. If you didn't have a Class 1 visit in year 2, you would remain with your Class 2 coverage at 70%.
And thus, the important thing that this is illustrating is the corridor for Class 2 that's being proposed in this specific incentive design is a Class 2 corridor of 70 to 90%. You can never be below 70% for Class 2, no matter how many times you don't have preventive services year over year. And then conversely, no matter how many times you have preventative services year over year, you always cap out at 90%. So that's why you're seeing the very top part of the year 3 row is still 90%, and the very bottom part of the year 3 column is still 70%, because this is establishing a corridor of 70 to 90%, a sliding scale, depending on what had happened in your year-over-year use or non-use of preventive services.
So there's 2 more things to note. One is if you saw only a premier dentist, that percentage would change because premier coverage starts at 70%, so it could drop to 60%. And the highest it would go is 80%, again, because it starts at 70%. The other thing to note is new hires would always come in, no matter when they are hired during the year, with Class 2 coverage at 80%. They would still have preventive services at 100%, Class 3 at 50%, assuming that they see a preferred provider, not a premier dentist.
And I just want to highlight before we move on that part, there was a lot of internal deliberation as we were coming up with a specific proposal for presenting to both boards and then ultimately for consideration possibly in a decision package behind and answer Dan's question about what's going on kind of market-wide. Generally speaking, incentive-based designs are not a significant part of the dental employer-sponsored insurance world. This is something that we've heard a lot from school employees and from board members directly, because it was a prominent feature of the WEA plan, which was a pervasive plan available to many school employees, but not all school employees, that there was this incentive design. When we looked at the WEA design, those who aren't familiar with it, everyone started at 70%, and you couldn't get below 70%, but you started at 70%. We were thinking and proposed to start at 80%, the middle of that corridor of 70, 80, 90%, so that there is an incentive to get services. That incentive is to not move down to 70%. It's actually, there's two incentives. There's the ability to get up to 90% by getting preventive services, but also the avoidance of going down to 70%. If we just started at 70%, there's only a carrot. There's not also the potential for a stick. And we thought that starting everyone at 80% felt like a very good way to heavily encourage preventive services, which is kind of a pervasive theme of many of these benefit design proposals throughout this entire presentation. So I just wanted to draw a very fine point on that. And again, Ellen, for simplicity, we have 50 slides here on this. For simplicity, we focus on the PPO aspect and the PPO percentages, but just driving home Ellen's point that this entire design idea also applies to the premier study. It's just the slightly different cost shares. And we'll make sure to have a slide in May that draws the distinction, at least the base level distinction between PPO and Premier, so that it's easier to follow. Realizing that as I'm looking at this presentation, at least having one slide about that might have been helpful at the end of the day. So we'll make sure that that's in the third presentation. But just wanted to highlight some of those extra kind of features that are underlying this very technical proposal. This is definitely the more complex of the 5 different benefit proposals. So I'm going to pause for any questions before Ellen moves on to the child deductible.
I just have one comment to add, which is under the WEA plan, preventive services also started at 70%. And in UDP, they've always been 100%. So there's a difference there as well, which is reflected in the appendix. Okay. Slide, please. So now we're going to talk about deductibles for children. And let me explain the current use of deductibles. Every member is subject to the $50 deductible, which does not apply to preventive services. And if there are 4 or more individuals covered together, the maximum overall family deductible is $150. Subscriber and a spouse and 1 child, right now it would be $150 as well. Slide, please. Proposed change here is to eliminate the $50 deductible for children up to the age of 15. The family deductible would remain at $50 per person, up to $150 a year. However, an account with a subscriber, a spouse, and 1 child under the age of 15 have only $100 a year overall deductible. It's a change from the current. Slide, please. This slide highlights the use of deductibles, and I want to spend just a little bit of time here. There were 12,000 children out of about 53,000 total children in the SEB program, who used deductibles. And the reason that the numbers down below are so different is because Class 1 preventive services have never had a deductible applied against them. So those 44,000 people who were seen in Class 1, they didn't pay a deductible, and they won't pay a deductible, and they never did. But deductibles would be applied for Class 2, Class 3, TMJ. So just to keep in mind, the right side of the slide is where deductibles come in.
I will highlight before we move on that in the appendix, the Delta PPO book of business also highlighted is a current feature of the Uniform Dental Plan. Not as prominent to have child deductibles generally waived. And that the WEA plan, like the proposal here right now, waives children's deductibles also up to the age of 15 with, I believe, the benchmark of the WEA plan as well. TMJ.
Before we move on, I just thought I would pause and see if there's any questions on this before we move to the next. Next option is TMJ, temporomandibular joint services. Next slide, please. Currently under UDP, which covers only non-surgical benefits. I know that some people have talked about surgical remedies. Surgery is covered under medical plans, not here under dental. So non-surgical benefits, which is usually spacers or retainers, are covered at 70%. And currently, there's a lifetime limit of $500. Proposed change here is to increase the lifetime benefit from $500 to $5,000, to also set an annual member benefit limit of $1,000. And this is very consistent with the book of business as reflected in the appendix.
With one exception, UDP pays a higher percentage, 70%, whereas the market generally is 50%. But the 5,000 lifetime, 1,000 annual, that's pretty pervasive. The higher reimbursement of 70% coverage is higher than the typical.
Next slide, please. As you can see, there were 531 people who took advantage of TMJ remedies in 2021. I think it's important to note that the 2021 utilization numbers, that was during the pandemic, numbers were probably down quite a bit, and we don't really know exactly how they would pan out in a non-pandemic year because we're not quite back there yet. Okay. Any questions on any of the options before we move forward? Okay. Hearing none, next slide, please. We're going to move into a discussion of prioritization. So this slide shows the options, the benefit changes proposed on the left side. And the order is the same order in which they were presented, which is based on the percentages of the SEB population who could be impacted by such change. So again, excluding preventive visits has the highest possible impact. Deposit filling has more than incentive plan design. Eliminating the children's deductible has a slightly lower percentage, and then TMJ. Slide, please. You may remember that I said last month that I would come back with ranges of cost, small, medium, and large. And you may notice that they're not present. The reason is, after analyzing the data, it really didn't warrant making an artificial distinction of small, medium, and large. And so we've decided to look at this in terms of estimated premium impact. And this ranking is, you may notice, the reverse of the previous slide. This is the lowest impact to highest impact. TMJ is at the top here. It has the lowest costs involved. And then children's deductible moving down through, and the most expensive would be excluding preventive visits.
Before we move on, I want to highlight why we're going to show both boards information about both programs. And it's just an important piece that I've been thinking about lately, that even though in the SEB program, it is all employees, the entire coverage of the program is employees, all of the members of the SEB program, one day when they retire, likely have eligibility in the PEB program as a retiree. And so, you know, as both programs move forward and are looking at different benefit proposals, you'll often hear me talk about an importance of trying to keep the benefits fairly aligned. And part of that is that transition of membership from SEB into PEB at the point of retirement. And so the impact of decisions by the SEB program, just wanting to have a general awareness of the implications that could happen for those same exact individuals once they become PEB retirees. So we're going to highlight things about both programs to both boards because of that interrelationship and transition of members in and out of the programs or from one program to another. So that's why you're seeing some PEB things. It's purposeful because we want to make sure that you're aware of the dynamics. Each board is aware of the dynamics of the other's programs and some of the considerations that go into play for the different populations that you serve. But ultimately, when you think about it, almost the vast majority of people, I can't say everyone has eligibility in PEB because I know Barb Scott would cringe if I said that because it's certainly not true. But many, many folks who are in the SEB program one day will be in the PEB program. And so we want to make sure you're just thoughtful and aware of the implications in the PEB program.
Thank you, Dave. One thing that I'd like to highlight on this slide is the third box down. You'll notice on the SEB program, it's covered composite billings. And on the SEB side, it's in the incentive plan. And those boxes are reversed on the following line. The reason for this difference is that there are changes in the demographics between SEB members and PEB members, and that accounts for the cost implications of this.
And that also reinforces why we backed away from trying to describe these as small, medium, and large. When we actually look at the specific numbers and projections that we're looking at, and once we get to a decision package, we will need to say specific numbers. We just don't want people to get wedded to a specific number at this point. Those minor differences really got us to go, there's no real distinction here to draw. And as Ellen goes into some subsequent slides, the top two on this page from a cost perspective are very similar and pretty low cost. The bottom three, regardless of their ranking, are all fair in each program, their ranking in each program from a cost perspective, they're all pretty similar to each other. And so we didn't want to inadvertently suggest one of them is vastly more costly or vastly cheaper than the other. And that's why we backed away from describing them as small, medium, large. But there is some more information that will be on some subsequent slides related to finance.
Any questions on this slide? Slide, please. So just a reminder, we're looking at premium impacts and who pays the premium. For the employees, dental benefits are 100% employer paid. Just a reminder, any increase in state costs requires a decision package we've talked about, which would be prepared in the fall of this year. And in isolation, any single change may not change the funding rate, but the cumulative effect of benefit changes could change the funding rate. So that's why it's important that you consider all of these pieces. And just a reminder for retirees, COBRA, and other self-pay members, like people on leave without pay, premium impacts would be borne totally by the member. Slide, please. If we looked at funding for all 5 benefit proposals, the overall estimated PSPM, which is per subscriber per month, increase for each program would be between $5 and $7. And a reminder, this is based on 2021 pandemic period utilization. So again, the numbers may be out of whack with actual experience as we move forward. The actual premium increases may vary, and as a self-insured plan, ultimately the state has claims liability. Dave, would you like to speak to the overall impact of this?
Yes. So again, the top piece is if all 5 of these, exactly as proposed, were put together as an omnibus package and everything was cranked forward and implemented, the estimate per program is $5 to $7 PSPM. So I want to do some of the bigger math as to what that pans out as a full decision package with that range. When you take that low end range of $5 and that high end range of $7, and you look at what $1 equals in the funding rate, because we're looking at the impacts to the funding rate of also being in that $5 to $7 range, $1 in the funding rate is roughly $1.5 million is the math we use. It slightly varies from that depending on the PEB and SEB programs, but it's on average $1.5 million. So we're saying that this costs from a funding rate state perspective, for a single program, it's somewhere between $7.5 million to $10.5 million. And then because it's the same range for both programs, and we would anticipate that any authority would be given the same authority to both programs, the overall package for both PEB and SEB is on the magnitude of $15 to $21 million. So that is a significant amount of money. And in fact, it's as a proxy, you'll remember we've had several years of discussions about the employer paid portion of the long-term disability benefit. And the most recent decision package for the 2022 supplemental budget process that was put forward and not ultimately picked up and included in the state budget was around $18 million for both programs. And that was to get to a $1,500 benefit. My point in drawing this figure is the magnitude of this omnibus proposal of 5 benefits for both programs is very similar to the magnitude and cost request of the LTD decision package. So I just say that because $5 to $7, especially for a retiree, a COBRA member, a leave without pay member, that's something that would be borne directly by them. In most of the employee settings, it's not something that the employee feels. But from the state funding perspective and the SEB organization perspective, when they pay the funding rate to the healthcare authority for all eligible members, that's real money. That's, we're talking $15, $21 million if everything is put forward. And what we're thinking is, this decision package would describe all of these efforts, these different proposals, these 5 different options. We could remove one of them and not even include it in the decision package, especially if both boards are saying, we don't really think that we should even include this, whatever plank. I don't even want to say one because I don't want to nominate one. But if both boards are like, we don't like a certain one of these, we really only think the conversation should be about 4 of them. If both boards had the same list of 4 and didn't want to talk about the same one, then we would, reduce the decision package drafting to a 4 benefit proposal instead of a 5 benefit proposal, or whatever that number is. But I say all of this as, the part of the next part of this board meeting, and then hopefully in May as well, is conversation about, there certainly we may not be in a fiscal situation where people want to put a $20 million investment in the PEB and SEB programs on dental, but they might be willing to do something less than that. And we want to be able to describe in the decision package the general preferences of both boards. I don't anticipate that necessarily both boards will have the same preference, but we want to be able to acknowledge the conversation that's had here at each of the board meetings with regards to the proposals, and then ultimately, the governor's office and the legislature, as they're crafting their budgets, would be able to see the incremental cost of each of the options, understand what both boards' perspectives were, and then if they want to make an investment less than the full package, they would be able to pick and choose among that, taking into consideration what the board's insights were about the importance or prioritization of each of those. Because I know, many of I'll go back to the early days of the SEB program. There was always a question of, well, can we just ask for more money? Well, we can always ask, but we're not always going to get. And so just that's kind of the main crux of this prioritization discussion as we move forward in the rest of this presentation. And let's see if there's any questions about that big picture that I'm laid out. There's one bullet on the slide, but a whole lot of context.
So when we looked at these individual options, it became clear that TMJ and the child deductible proposals are pretty small and can be considered together. There really doesn't seem to be much use in separating them out and determining the actual impact. So combined, the premium impact would be under 50 cents PSPM for SEB, under 25 cents PSPM for PEB. And remember, PSPM is per subscriber per month. For the state and SEB organizations, from a budget funding perspective, these 2 changes combined are unlikely to impact the funding rate. Slide, please. It's a completely different story, however, for these 3 options. So we looked at the incentives, the composite billings, and the annual plan maximum together. And for each of these three proposals, for each of PEB and SEB programs, the estimated impact is between $1.25 and $2.25 PSPM. For the state and SEB organizations, from a budget funding rate perspective, any of these changes individually would impact the funding rate. So I think as you consider these various options, we would like to know, are there any proposed options that board members think should not be evaluated further? As Dave said, if both boards came back and said, hey, drop option X, it would be easy for us to drop option X. We also want to know, is there anything that board members think should be prioritized at the very top, and why? It's really important to have the understanding of what makes it more important or a higher priority. And ultimately, any changes would be subject to funding in the budget and approval by both boards.
As we move into questions, I'll also say if there's other additional information that you're hoping to see, this is a three-part mini-series. We're in part 2, coming back in May. So if there are other context and information you're interested in, also please raise that. And I see Pam has the first discussion point.
So first, I'm going to beat Dan to the question because, you know, we always want to compare Delta with UDP. But really, wondering if we could put some prioritization on crowns. I cannot tell you how many people have contacted me and delayed dental care because of the cost of the crowns, and they're not covered at a very high percentage rate. So if we could have a further discussion on moving those up in the prioritization, that would be great. Thank you.
Pam, let me ask you a question just because I would have to say, wait, do you see that as something that's more important than the specific proposals, or where do you place that in the hierarchy of everything? That's the really challenging question here. And that's, to be clear, that's why, you know, when we were thinking about how to present this to the board, we naturally went towards breadth of the population impacted by a change. If there's a change and it has a cost and is borne by the entire pool in some way, shape, or form, our tendency was to go in the direction of breadth of the population. And so that's what we ended up using as a broad criteria. So I'm curious, when you say crowns, how do you kind of place that? You know, if at some point you have to say this or that, where do you kind of place crowns in the hierarchy?
And I knew you were going to ask me that. I would put them in that mid-level range. Covering it 50%, it does. It makes it where you don't want to pick it. You're like, do I really want to pay that much out of pocket? If it could be in the mid-level, rather, you know, bump it up to 60, 70, 80%, a better percentage rate. And then also question, because I know, were the numbers based on prior COVID or this last year? I can't remember.
Utilization was 2021, which obviously has a big asterisk of unknown pandemic influence, but we went with utilization within the Uniform Dental Plan in 2021 as our best available this population and its current pooling information.
Yeah, because just a wondering, I have, you know, having a good relationship with my own dentist, how many people put off dental care because of not wanting to get COVID. I know he encouraged me not to come to the dentist. So I'm putting a wondering out there. I don't have any evidence other than what my dentist and I spoke up to, but wondering if those numbers will change when we look at this next year. So it's just a wonder.
One thing I can guarantee you, Pam, is they are definitely going to be different when we're not in the pandemic. And I think we all presume the numbers will be higher. They won't go in the opposite direction. But we do know that historically in the PEB program, the general nature and utilization of services is pretty consistent. And we also know, unfortunately, that there are many, many, many individuals who do not get even preventive services, which is why you see as a hallmark and theme among these, trying to encourage and incentivize or promote preventive services, whether that's removing the deductible for children to instill good behavior and reduce that financial barrier from a parent having to decide whether they want to proceed with services or not because of that deductible, whether it's removing that from the annual plan maximum so that people aren't trying to balance in their head that there's any negative impact of getting a preventive service, whether it's an incentive benefit design that allows higher coverage for fillings, and maybe you won't need fillings if you're getting those preventive services in the first place. That's kind of the theme you're seeing here across those. And part of that is driven by the very long data tail in PEB, where there is an unfortunately low utilization of preventive services. And we would expect, both schools, both PEB and sub pools to have similar utilization of that. We have done many things over the years to try to increase dental services. I'll say, it's very rare that I acknowledge or know that I have a big blinder. I'm a very unusual personal dental patient. I've said this to the internal team many times. I go every 90 days for my deep cleanings. I always have. I can fall asleep without a Novocaine shot. If I have a filling, I love going to the dentist. It's and I know I'm unusual. I know that, well over half of the population has no interest in ever seeing a dentist. So, trying to find things that really encourage preventive services is what drove a lot of our proposals, as you see. So I appreciate the piece about crowns. You're right. That is incentive design, crown coverage. Those are definitely things that have come up quite regularly from the school employee world. It's also a matter of prioritization.
Well, Dave, you've got me beat on wanting to go to the dentist. I thought I was bad. I've been seeing my same dentist since I was 3 years old, and I don't want him to retire. But yes, if we can get more coverage for those crowns, that would be great. Thank you.
Any other insights or comments from the board? Again, specifically, if there's, something that, anyone feels might not need to be on the table for further discussion, or comments about how we've presented it. Again, our prioritization that we've highlighted would be likely, and I'm not going to commit to what would be in the decision package. There's many, many pieces for the agency to still think about, but a criteria that people seem to be coalescing around, at least today and in recent weeks, has been breadth of the population that would be served. And that's why this presentation was presented in the order that it was broadest implication to lowest breadth of impact. Curious what people think about that as a criteria, or if there are other criteria that people think might be appropriate to use when looking at these proposals and quote, prioritizing them. I also recognize this was 48 slides and a lot of information, and I told you all that this is a 3-part mini-series, so it's perfectly fine to want to digest this, and we will definitely be back in May to hopefully have had this simmer for a little while longer. My intent is not to bring a specific resolution for voting. I don't know that that's particularly helpful in this instance, especially when a key factor at the end of the day is what is ultimately funded from a budget perspective for any benefit change here. So I think the goal here is to just be able to get a sense from the board of any kind of prioritization criteria so that we can describe that as part of the decision package process, so that the influence of the board about, where to draw this line if the legislature and governor's office in fact do decide to pick up this decision package in part or in whole, that they have that information. So again, no pressure to answer today, but just a call for any other initial thoughts. Definitely be back in May to hear your kind of 30-day simmer reflection on them, as well as bringing back, I think there was a question or two. We'll make sure that it's very clear in our slides about the difference between Premier and PPO, so that that's captured.
The analysis of preventive.
in the analysis of the preventive piece. Is there any other information that board members would like us to put together in that May final presentation on this topic? My email door and Ellen's at the end of the slide deck is always available. And so, Ellen has her email is right here on slide 47. So if there's something that comes up that you're interested in, board members know how to contact me. Here's Ellen's email, and I'll turn it back to you, Lou.
All right, thank you, Ellen. Thank you so much. I know that's a long presentation. Appreciate you going through that with us. Next item is the call for public comment. Is there anyone on Zoom that would like to provide comments? We're going to gather a list of the speakers, and then Dave, if you could manage those from the room, I would appreciate it. If you are interested in speaking, please raise your hand. I see Mr. Fred Yancey right off the bat there, Dave, and Julie Salvi.
That's who we have so far on our list as well. So let's start with Fred, then we'll go to Julie. And if you're interested, just keep raising your hand or put a message in the chat. Jessica's monitoring for that, but we'll start with Fred and then go to Julie.
Thank you, Chair McDermott, members of the committee. Can you hear me okay?
Yes, Fred.
Yes, sir.
Okay, thank you. Thank you for the day's work, by the way, and I'll be brief, but I wonder, when you're talking about dental design, what if it's possible to do a projection raising the maximum benefit allowed. I and many others hit that maximum even without preventative services, even though we use those. But today's dentistry is a whole different world than it was 20 years ago. You know, they used to just pull teeth and give you dentures. Now it's almost strictly implants and crowns. And so you hit that max way too early. And I don't know what the impact would be if you projected raising that max, because I noticed that was not, you raised it by virtue of excluding debit of preventative services to the max, but I'd like to see a bigger change. That's all I have to say. Thank you very much.
And before we go to Julie, we don't usually necessarily have there's no give and take necessarily in public comment, but I will say to the board, and we can bring a little bit of information about this, that was a proposal that internally we looked at, and it was kind of the other main option compared to excluding preventive services. I can tell you that the breadth of the population that's impacted, Ellen had highlighted that the percentage of the population that hit 1750 was 4% of the population in each program, a little less than 4%. And then we also kind of looked at, well, what about the people who were at like 1500 or above? And that added maybe another 7-8%. So you're looking at about 10% of the population. When we looked at and extrapolated out projections from that, the cost of that type of change for impacting a smaller part of the population became the most expensive option on the table. And so when we started to think about breadth of the population, that's why the presentation today, you could come up with 8 different incentive design models. You could pick 3 or 4 different ages for children's deductible. You could come up with a couple of different ways to change annual plan maximum. For simplicity's sake, from our perspective, we put together what we thought might be more, again, breadth of the population. But I do want to assure folks, and we can bring back some information in May about it as well, that on annual plan maximum, we did look at that other piece. It was another proposal that we looked at, but our recommendation to the board ultimately was the one that we brought today about excluding preventive services to impact a broader population at a cheaper cost than simply raising the plan maximum. But we can bring some more information about that. I just wanted people to be aware that that was definitely something that was looked at, and we'll share a little bit more about that in May. Julie?
Thank you. Good morning. For the record, I'm Julie Salvi, representing the Washington Education Association. I want to echo what Pam had brought up about the interest in looking at crowns again. As you are looking at the prioritization of benefits and how it will benefit many people versus fewer number of people, one thing I would bring up is taking a moment to look at the equity impacts of that. There's a lot that we like in many of these proposals that are helping many people. But when we leave something like crowns at 50%, which is a very high cost item, I'm concerned that that dental care is out of reach for some, and it is only available to those who can afford that extra 50% of a very high cost item. So that was something I wanted to bring up. Our members have been very vocal of wanting better coverage of crowns, but also of moving back to an incentive system. So we do appreciate that you have brought forward these ideas and moving to an incentive system. Of course, they remember the plan they had before that went to 100%, and that is their preference, but we do appreciate the movement towards an incentive system. I want to bring up one more thing today that I would like the board to think about as we go into the summer. If you remember, in 2020, Senate Bill 6189 provided a safety net for SEB members so that they would not lose benefits due to the impact of the pandemic. If schools were closing, which we've still seen some this year where certain schools had to close for a couple weeks at a time when there was an outbreak, or certain members may have had to isolate or quarantine because of exposures, they would not lose benefits because of those impacts of the pandemic. Those protections end when the executive order, the emergency order ends, and nobody has a crystal ball of exactly when that's going to happen. But if it happens in the summer, I have some questions about how that may impact some individuals who may still be relying on that protection. Because as it ends, as the statute reads, the member can then demonstrate that they would continue their eligibility if their hours worked would result in benefit eligibility if it was applied to a full school year. But for employees who work during the instructional year, if school is out at the end of June and the pandemic ends before September, there's just a question mark of how they may be impacted. And we would like the board to consider some protection for those members so that their benefits would continue through the end of the school year and then be reconsidered in September if the pandemic happens to end during that window. So that, I don't know if that could be handled by board policy, emergency rule, or other process, but I would love to have the board consider that. Thank you for your time.
Thank you, Julie. We'll definitely, the unwind of the pandemic is something that I think a lot of agencies are looking at. Probably none more so than this agency, with the implications for Medicaid as well as the SEBB program. So this is something that we've been planning about, what guidance would look like to sub-organizations and school employees when that happens. I will say for now, we've purposely not shared specific information because it does depend on the time of the year sometimes, and we don't want to unnecessarily worry or promise, depending on where it is in the calendar. But it's something that there's a lot of thought of, and we can think about how to share some insights with the board as the board season progresses. Thank you for providing that insight. So far, I don't see any other requests for public comment. I'll just say, going once, going twice, turn it back to Lou.
All right, thank you, Dave. Thank you, Julie. Thank you, Fred. Our next meeting is going to be May 5th, 2022, 9 a.m. to 2 p.m. Dave, any final comments before we adjourn?
I do have a couple of final comments, more than usual this time. I'll start with what we think the preview of coming attractions is for May. We'll obviously have our third part of our dental discussion, and I hope board members really reflect over the next month about the prioritization and if at the end of the day everything can't be bought, you know, what are the prioritization criteria or specific proposals that you think should be kind of at the top of the list. I also anticipate that we'll have a conversation, probably part one of a two-part mini-series instead of a three-part, about vision benefits, as we're also anticipating possibly putting together a vision decision package for consideration in the next biennial budget. There was a allusion during Tanya's presentation that we'll have some presentations giving information about some of the large upcoming procurements. Not all of them, we won't do them all in one meeting, but we will plan to share some information about some upcoming procurements for the program. And we will have, I believe, the first executive session for this board at the next board meeting. We are eminently getting proposals and responses as part of the annual renewal process from the carriers, specifically the medical carriers, where there's usually a lot more work involved. And so we'll begin the series of executive sessions about the current status of the procurement with the proprietary rate information as it's in the negotiation process with the board. So do expect an executive session at the next board meeting. So that's for May. But I can't close out this meeting without one other kind of special comment, and that's to let the board know that Scott Palafox, my deputy director, who has had several presentations over the years to this board, is retiring, and his retirement is next Friday. No matter how many times I ask him about moving that retirement date, and he's pinned for feature right here for one last view by the board. But Scott is retiring after many years of service to the state, especially at the Healthcare Authority, and for the last, I'm afraid I'm going to mess up the number of years, but at least the last, well, he's been the deputy director since late 2017, and part of the PEB program since I believe 2014. But I just want to make sure to publicly thank Scott, and in particular for the SEB program, as I reflected about Scott's role. When the SEB legislation passed on June 30th of 2017, that was, July 1st of 2017 is when I became the acting director, because our illustrious chair became the interim acting director of the Healthcare Authority. And so a new program was being launched with me in an acting role. I had been the deputy, which was suddenly a vacant position. And in fact, it was the only vacancy in our entire division. And I turned to Scott. He was the person I turned to for more support. And those first 6 months of time with the division as the acting director, so that last 6 months of 2017, Scott and I were essentially performing the equivalent of what ended up being 4 jobs: the directorship, the deputy directorship. Scott at the time was overseeing portfolio management and monitoring, so all the carrier contracts. And we were beginning that stakeholder process, which ultimately materialized as John Bowden's role. And so for about 6 months, Scott really was a person that helped carry a heavy burden for the foundation setting of this program. And I just can't, in good conscience, let him go off into retirement without acknowledging that critical role. And especially in those early days, it's very hard to start a program of this magnitude when sometimes it's difficult to figure out where to start. And there were a lot of times where there was a lot of swirling, and I could never, privately or publicly swirl, except sometimes with Scott. And so I just appreciate the sanity that Scott helped me with during the early days of the SEB program. And as he was in the deputy role, there were a couple of big challenges that he had to help really shepherd through. We've mentioned many times that our call services and customer support center here at HCA is designed for retirees, and there are no retirees in SEB. But we did build up, and we contracted and then worked with our traditionally Medicaid serving customer service staff to have a technology support service, customer service center for school employees at the launch of the SEB program for use of SEB My Account, an entirely new venture for our work. And that was something that Scott worked with Renee and others to really shepherd. And then, of course, we all remember that there were thousands of appeals right after the launch of the SEB program right before the pandemic hit. And Scott was a big role in helping shepherd and in higher level appeals, helping adjudicate and making program decisions with hundreds of appeals. And so those are just a couple of things that I just want to highlight for the board about Scott's work as the deputy director as he tries to head off into the sunset. Still willing to extend that retirement date, Scott. I'll say that publicly. I've said it privately many times, and I know that next Friday is a real date. But I just want to thank Scott publicly for his work, the role that it had in helping set the foundation for what is today's SEB program. And I want to just open up, Lou, I don't know if you have anything that you want to say, but just want to make sure that there's an opportunity to thank Scott.
Oh, I guess I could say a few words about Mr. Palafox. Scott and I have been working together for, 25 years in one capacity or another. We've spent time together in the finance area for the old Medicaid division. We've spent time in PEB together. We spent time at child support together. It's been a long road, and I think Dave, Dave's comments are all spot on. Scott always was ready to be there, to dive in, to do the work that was necessary. He's 100% reliable. He thinks about issues correctly. He understands ramifications of doing this or doing that. And that's all you can ask for, really, is that someone is dedicated to serve the people that were charged for serving, whether it's one job or another job. It didn't really matter. Scott always was there to serve the people he was supposed to serve and do it to the best of his ability and hold himself to an extremely high standard and hold others to that same standard. And I've always appreciated him. I always could count on him. I always knew if Scott was working on it, I didn't have to worry about it. And that is not always the case. Sometimes there are things that staff are working on that you have to check in, make sure everything's okay, that someone's on it, that it didn't get dropped. If it's in Scott's lap, you didn't have to worry about it. So Scott, I hate to see you go, but I believe you've got 40 years in. Is that correct?
Yes, 40 years. I reached that mark on St. Patty's Day. So
okay. So I mean, after 40 years, I guess you're allowed to go. I mean, it doesn't seem like we can get much more out of you. You deserve some time with your family. I know you've got some young grandkids now, and you want to spend your time screwing off, playing with grandkids and enjoying yourself, and you deserve it. 40 years of faithful service. I couldn't ask for a better colleague to have. And I thank you for everything you've done, Scott, everything you've done for the state, for me personally, and for the agencies that you contributed to. You're awesome, and I love to see you go out healthy and happy. Sometimes people, unfortunately, wait a little bit too long to retire, and they don't exactly go out at 100%. And so I know you're physically doing well, and I know you're ready for the next chapter. I'm going to miss you.
thank you, Lou and Dave. And I just want to share a couple words for this board because, as Dave mentioned, him and I were here from the beginning of this, and a lot of work on our plates, and we knew that, right? And we accepted the challenge. But, as I think back of the beginnings of this board and the meetings we had where we were trying to pull things out, and we had a very quiet and conservative board, to where we are today, where we're actually gaining your insight and hearing a lot from you to get this program to be where it's at today. And it's been very successful because of that partnership. And so I want to thank the board first and foremost for allowing me to serve you in that capacity. And I appreciate the engagement we've had and the participation, the willingness that you had to be a partnership in all of this. I'd also like to give thanks to all the folks over these many, many meetings that have given public comment. We take our job very seriously here, and your comments do not go in vain. We make sure that we go back and look at what we have and make sure that we're on the right track when it comes to those comments. And if we're not, you have helped us get to where we are today. So I want to thank everyone that has shared in public comment over these meetings because we appreciate it, and it has made this program much stronger than it is today. Of course, can't go without thanking our carriers and our partners for the work that they've done in getting this program up and running. Certainly appreciate that work as well. And to Lou as the chair, awesome job. So proud to see Lou where he's at today, because as he said, we have worked many years together in various capacities. So try not to crack, but and Lou, just thank you for all that. And Dave, what can I say? Without Dave and his leadership and being the captain of this starship, I don't know what the program would have got to where it's at today. So thank you, Dave. Thank you for your leadership, your guidance, and your very judicious and insight as to where this program needs to be, and your methodical thinking of how we're going to get there. And that I'm going to leave knowing I feel good about the leadership that is still here within this program. And then finally, as many of the folks have expressed, it's the staff that has really helped support this program, not only in the request that you have made, not only in looking at what we should provide you, but all the other aspects that I think engage this program and the interest for me to come into the PEB world. I was in Medicaid for many years, and like Lou said, you know, we do a lot of work and we try to help as much as we can on the Medicaid side. At the end of the day, you may or may not get the recognition of what your hard work represents, because, you know, we mainly on the work that we did was on the provider side. And with providers, there's always more that you can do, right? So coming to PEB was an acknowledgement for me personally to know, not only am I sitting at the table with the board, with other authorizing aspects of this program to get to some of the decisions we make, but at the end of the day, I'm also a member. And that just having that understanding and feeling as we were bringing up the SEB board was a message that on the onset of this program that I wanted to share with you as well, is we care about our members because we are members, or we have family and friends that are members. So I'm glad that that trust that you gave into us to get us to where this program is today really is the heart and soul of being successful in building up a program like the SEB program. And for that, I just want to thank everyone for all that hard work into that.
On that note, I'm going to go ahead and delegate the authority for the chair position to Scott Palafox. And Scott, could you adjourn us, please? Mr. Chair.
This meeting is officially adjourned. Thank you, everyone.